Assalamu alaikum. Thank you, Mr. Chairman, for the great introduction. It's my pleasure to be here, and I thank the organizers for inviting me to present in this wonderful meeting. The past 2 days, we have come across very exciting lectures, very informative, and I'll give you the best of SSR 2024. I have no financial disclosures. I would just go through, in the coming 20 minutes, the best of the SSR. I'll give you the cornerstones of how we went through the process of selecting the abstracts. We had the research committee, which was headed by Professor Suleiman Al-Mayouf, and we received 165 abstracts. Duplicates as well as previously published abstracts were excluded. We reviewed 94 abstracts on a stringent criteria using a scoring system. Any committee member who had who was co-author was excluded from reviewing his abstract paper. Finally, we had a Zoom meeting that we finalized the results, and a total of 71 abstracts were selected and 23 abstracts were rejected. And I take the opportunity of presenting the abstracts were of great interest, but I would apologize. We had many interesting abstracts, but because of the short of time, I may just go through a few of them. The subjects that are included: rheumatoid arthritis, SLE, spondyloarthritis, vasculitis, and others. I'll walk you through rheumatoid arthritis. First, as you know, that randomized controlled trials, usually they concern about efficacy. In real practice, what we have a large number of patients that do not fit into the criteria of randomized controlled trials. Registries are the ones that highlight the evidence for how to deal with patients of these kinds. The real-world clinical remission of rheumatoid arthritis from the South Three Arthritis Registry. The aim of the study was to assess the remission rate and analyze the factors related to remission. It is a prospective study, and these are the RA patients included in the SARS registry, receiving standard of care from 5 executive centers. And the inclusion criteria was more than 16 years of age who fulfilled the 210 ACR criteria of rheumatoid arthritis. And they had to have at least 6 months of follow-up to be included in the study. We had 1,760 patients included. This is one of the largest multi-centered study in Saudi Arabia, of which 956 patients were included according to the inclusion criteria. The mean age was 47 years, and the follow-up was about 5 years, 70 months, which ranged from 6 months to 365 months. The biologics were seen in 47% of the patients were given. Targeted DMARDs were seen in 12% of the patients. Those patients that were diagnosed after 218, they achieved a remission of 54%. And according to the long duration, as well as the HAQ at the last visit, was significantly associated with achieving remission. In conclusion, 50% of our cohort was consistent with other studies in achieving remission. And long-term follow-up, as well as the low HAQ, was significantly seen in our patients, which are the predictors. This highlights further studies to be done, and we encourage everybody to enter the cases into the registry to have more robust data that we have in further conferences. Our next topic, we have the JAKs, which is first introduced in 2012. Tofacitinib was first FDA approved, and since then we have more on the downline coming up. Here we see assess the efficacy and safety of upadacitinib through 6 months in the real-world population of patients with rheumatoid arthritis. This is the UPHOLD trial. It is an ongoing multi-center, non-interventional prospective cohort study, including moderate to severe rheumatoid arthritis in a 6-month interim period, including from October 2020 to 2023. The main primary endpoints were DAS28 CRP remission at 6 months. Safety was assessed with a full analysis set, and patients that received 1 or more OPA dose were included in the study. The DAS28 CRP remission and low disease activity was analyzed by the modified FAS and modified non-responder imputation approach, which is more stringent. 1,732 patients were included. 1,715 patients received 1 or more dose of OPA, in whom there was a 30% dropout rate. And you can see that in randomized controlled trials, if they study there's a dropout period more than 10%, the value of this randomized control is less significant. But in real world studies, up to about a 20% dropout can be expected. Discontinuation of these was because of adverse effect or lack of efficacy. Those that completed the trial, 1,104 patients, the 44% reached the non-responder imputation, and 55% showed an observed. This DAS28 CRP remission at 6 months was achieved. At 6 months, low disease activity was seen in 56% of the patients, and as observed analysis was seen in 70%. Regarding the adverse effects, the 36% have adverse effect, and all adverse effects were seen at serious adverse in 4.5%. 1.57% had serious infection. Those were mainly because of the COVID infection. The adverse effects that include less than 0.5 was seen in elevated serum creatokinase levels, malignancy, non-melanoma skin cancer. VT was seen less than 0.4%, and deaths 0.3%. There are no cases of MACE was reported. In conclusion, OPA is effective for the treatment of moderate to severe rheumatoid arthritis in real-world clinical practice, and approximately half of the patients, they achieved a DAS28 remission at 6 months of treatment. The risk-benefit profile was seen as that in phase 3 clinical trials. Our next topic is about cycling of JAKs, and this is an interesting topic. As we have seen in TNFs, what's the effect of cycling between TNF blockers? Here the study includes overall safety of JAKs in the Middle East and clinical efficacy of cycling from tofa or baricitinib to upadacitinib. The study included from May 2015 to May 2023, included the Emirates, Saudi Arabia, and Jordan. Drug retention, drug safety, and reason for switching between the due to ineffectiveness or adverse effects were studied. A total of 186 patients were included. TOFA was included 67% of the patients, BARI in 25%, and UPA in 30% of the patients. And the mean drug retention for TOFA, as expected, is one of the longest drugs that is available. It was 27.7%, and months. Okay, BARI was 17 months, and UPA was 11 months. Before the addition of UPA, there was 51 months of JAK drug exposure in which there were 2 cases of varicella zoster reactivation, 1 DVT, and 0 MACE. After cycling between tofa to berry, there were three patients, 18 to tofa to upa, and berry to upa in 9. There was overall 51 months of JAK exposure after the starting of upa. These showed a varicella zoster reactivation in 1 patient, and there was 0 DVT or MACE. Overall, over 6 months, there was low disease activity that was of statistical significance regarding the CDAI, the DAS, ESR, and the CRP after 6 months, in comparison with the 6 months. In conclusion, switching from non-selective to selective JAKs is feasible and safe and may improve disease activity outcomes in patients who have failed previous JAKs. The next abstract is the bacterial composition shifts of gut microbiomes in patients with rheumatoid arthritis in association with disease activity. This is an interesting abstract that has been of great interest, especially that we are concerned, which each person has a different footprint of microbiomes. So the study aimed to dissect the differences in gut microbiomes associated with rheumatoid arthritis in comparison with healthy individuals. And in addition to identify the shifts in the bacterial community in association with disease activity. The V3, V4 hypovariable region of the 16S messenger RNA was sequenced, and 60 stool samples were collected from 45 patients with rheumatoid arthritis and 15 from healthy subjects. Here, the results showed that there was a direct association between the bacterial diversity and disease activity in rheumatoid arthritis patients. Those in remission in the graph, as you can see, those in remission, there was a predominance of Firmicutes, bacteria, and those with the high disease activities, the predominant bacteria was the bacteroids. So in conclusion, the overall shifts in bacterial composition in different disease status can confirm the cross-linking of certain genera either to causation or progression of RA. So further studies are required to further help us in identifying for disease activity in relation to the gut microbiome. One of the interesting topics, and there was a hot discussion yesterday, difficult to treat rheumatoid arthritis, frequency and characteristics. The aim of the study was to determine the frequency of difficult to treat rheumatoid arthritis and characteristics. The study was a cross-sectional study that included rheumatoid patients. The G1 group included the patients, including the Euler definition of difficult to treat rheumatoid arthritis. And G0 was the not difficult to treat rheumatoid arthritis. They studied the social demographic data, disease activity, and the biological markers. 150 patients were included, of which 10% were difficult to treat rheumatoid arthritis. The factors that were associated with of clinical significance was smoking habits, DAS28 ESR score, the rheumatoid factor, interstitial lung disease, patients on steroids. These were the predictive factors of difficult to treat rheumatoid arthritis. In conclusion, the study showed that the frequency of the difficult to treat rheumatoid arthritis was 15%, and the frequency has been varied between 5% to 20% in the literature. Factors are associated, smoking, high rheumatoid factors increase DAS20 ESR and CRP as well as ILD. So these highlights in any patients that we have these factors to be more concerned and to have more multidisciplinary approach to get the patients into remission. Then we go to the systemic lupus erythematosus. This study aimed in providing a comprehensive description of patients receiving belimumab, assessing the clinical efficacy, fatigue scores, and tracking changes in biomarkers following the therapy in a real-world setting. We have the opportunity that we have biological agents that can be used in SLE, and randomized controlled trials have been very impressive. And we can see in the real life what's the evidence we have. This is a retrospective study. They included 3 tertiary centers. These included the patients that had failure to standard of care therapy. Study included from April 2022 to April 2023. The patients included should complete 12 months of therapy. This included demographics, the clinical features, as well as the patient's reported outcomes and fatigue scores. The values that were evaluated should be at baseline, 6 months, and 12 months. Regarding the results, 36 SLE patients were enrolled, 83 were females. The mean duration was 10 years, and the mean SLEDAI score, it decreased from 10.8 to 2.65 from baseline to 12 months of therapy, as well as there was significant decrease in the patient-reported outcomes related with the patient's global assessment, the physician global assessment, the visual analog scale, the fatigue score, as well as SLEDAI score. In conclusion, belimumab, when used as on therapy, demonstrated remarkable efficacy in inducing mild disease with a SLEDAI of 0.25 in SLE patients, with significant improvement in fatigue scores. These findings underscore the effectiveness of belimumab in real-world clinical practice. Large multi-center research to define more should be undertaken. Then we move to the next, spondyloarthritis. Here we have the, this abstract is from Kuwait, which from the Kuwait SPAR registry. They show there's gender differences in patients with spondyloarthritis and the differences between the male and the females. This is the observation cohort study. And it included 119 patients from the SPARs attending specialist rheumatology clinics in Kuwait, which included a study from February 2022 to April 2023. The mean age was 48 years. 53 patients were males and 86 were Kuwaitis. There was 58% of the patient had psoriatic arthritis, and 32% were ankylosing spondylitis. And non-radiographic axial SPAR include 2.5%. The females had a high ESR and a low hemoglobin, as well as iron deficiency anemia and obesity, which was of statistical significance. In the males, the high proportion was non-Kuwaitis. Current and ex-smokers, IBD-related SPAR was more common in them and had more ischemic heart disease, as well as elevated ALT, creatinine, and uveitis was of clinical significance. In conclusion, SPAR patients in Kuwait, PSA was more common in females, and IBD-related SPAR was more common in males. And females had a high ESR level, low hemoglobin level, while the males had high ALT, creatinine, uric acid levels, as well as uveitis. One of the interesting topics also is exploring the therapeutic potential of steroids and lidocaine injection in the sacroiliac joint from naive axial spondyloarthritis. It included 136 patients after meeting the ASS criteria. They including 2 groups. One group with 67 cases involving dexamethasone with lidocaine injections were given. 1 minute? Okay, sure. Group 2 is 69 cases. The control group was given saline injections. The comparison was done between the 2 groups, and it was seen that There was improvement in all parameters, as well as the VAS, the ASDAS, and the SPARC score values, except for the erosions, and as well as the BAS-5. In conclusion, the steroid and the lidocaine injection demonstrated remarkable improvement in the pain, function, spine mobility, the bone marrow edema, as well as the fat in a time frame of 3 months in naive SPA patients. And regarding the matrix metalloproteinases in spondyloarthritis, one of the interesting topics that will arise, what's the role in SPA patients? 82 patients were included, and ELISA technique was used to measure the MMP3 levels. And it showed that it was associated with HLA-B27 with increased levels of MP3 in patients. And it was suggested it had an implication in the pathogenesis of SPA. And to have more further studies to show it's related to the causation or in the disease activity. Here we had a meta-analysis, which was a systemic review, including the JAKs, IL-17, and JAK inhibitors in non-radiographic axial spondyloarthritis. These are the patients that we usually see in the patients. They are females, multiple problems associated with fibromyalgia, and it's not like ankylosing spondylitis. Once you give the biological therapy, there's a good number that have a good outcome. These are the kind of patients that keep you thinking what's to be given next. In this systemic review, we had 12 RCTs, 1,937 participants, TNF inhibitors. There were 9 RCTs, IL-17 inhibitors were 3 RCTs, and JAK inhibitors was 1 RCT. In the total analysis, there was a significant improvement in the ASDAS-40, the ASDAS, as well as the BAS-TI, and the adverse events in the placebo group were lower than the treatment group. But because the IL-17, it was only 2 studies, randomized controls, and the JAKs was only 1 study, which was the UPA. It was an inconclusive study regarding the subgroup analysis. As meta-analysis to be carried out, you have to have at least 3 randomized controlled trials. Yes, okay. The last is on the osteoarthritis. One of the new drugs is anti-nerve growth factors in hip and knee osteoarthritis. It showed that it is a promising drug, and overall, it made, in comparison to placebo, it showed that it had a significant improvement in the WOMAC, as well as the global health assessments. But because of safety reasons, the FDA has withheld the approval of this drug. With this, I conclude. Thank you very much.